So now we start with this topic. What is this topic? This topic is what is visible on the screen to all of you. That's what I'm trying to come across, guys. That this topic is visible. You don't need to study it to understand what we are reading, everybody. What you can see, everybody, you can see some bhangapan in Hindi, or you can see some squint, everybody. Yes. In this image, it is very abundantly clear that the patient's right eye is looking straight, but the left eye is looking up or down somewhere. Yes. So we know as soon as we see such an image that we are talking about a condition or a disease called as squint, which is also known as strabismus. Now, again, squint is probably that one topic that we all of us are afraid of during our third, first, and even after that, because nobody teaches it to us, because we do not develop an interest in it, and that is why we always keep saying to ourselves that this is a difficult topic. Yes, it is a difficult topic. I'm not denying that fact. But it is not difficult to the proportions that we make it. Again, it is about moving seamlessly through a topic, taking steps, baby steps. Okay? And that is what I will be trying to teach you on how to take baby steps to become confident in squint. Okay? So, by this image, all of us are at least clear of what squint is. Yes, sir. Squint is deviation of the eyeball. Without going into the definitions, I say when one or both the eyeballs are deviated, it becomes a case of squint. Okay? Let's understand further. When I look straight, both my eyeballs are looking straight, everybody, at the same object. I can see only one image due to that. If I look up, both my eyes go up. If I look left, both my eyes will go left. If I look right, both my eyes go right. Yes? Wherever I look, both my eyes act as friends and always go together in that direction. When this friendship is broken, basically when one or both the eyeballs get deviated in different directions, as in this case, the right eye is looking absolutely straight, but the left eye is deviated. We call it a case of squint. Okay? Clear about what squint is, first of all? Now, why does squint occur? That's the question. So squint somewhere is a problem in the ocular movement. Can I say that in loose English? Yes. So that means the problem in ocular movement must be due to some problem in extraocular muscle. Yes. Because ocular movements are a function of extraocular muscles. So let's understand it. Let's say I have a muscular disease. Let's say I have a myasthenia gravis, I have a muscular dystrophy, muscular atrophy, something like that. My muscle is not functioning. So if my muscle is not functioning, my eyeball will not be able to move in a particular direction. So I will end up having some kind of deviation. I will end up having squint. Or let's say scenario number 2, everybody. My nerve is paralyzed. I hope all of us remember the famous mnemonic through our anatomy, SO4, LR6, O3. All the extraocular muscles are supplied by cranial nerves, everybody. Third nerve, fourth nerve, or sixth nerve. So if I have any problem in third, fourth, or sixth nerve, my respective muscle will not be able to function properly. And again, the end result comes that my ocular movements are compromised, leading to some deviation known as squint. Bottom line comes that the problem stems from extraocular muscles. So that means to start the chapter of squint, what we need to be aware about is the basic functions of extraocular muscles, everybody. And that is where I begin my squint topic with actions of extraocular muscles. So my first question to all my students, how many extraocular muscles are there? I know a lot of you are saying 6. I know a lot of you are wrong. Yes, there are not 6 extraocular muscles, everybody. There are how many extraocular muscles? There are 7 extraocular muscles. Yes? 7th is LPS. We tend to forget it. Out of the 7, 6 control the ocular movement. But actually, there are how many extraocular muscles, everybody? There are 7 extraocular muscles in each eye. Let's see the names. Let's see the functions, everybody. Number 1, LPS. What is the full form of LPS? Yes? Levator, palpebrae, superioris. Levator, palpebrae, superioris. Now if you ask me, sir, what is the action of LPS? I will say the name is the action. Levator. Levator means elevation. Palpebrae. Palpebrae means eyelid. And superioris, by simple English, means which eyelid? Upper eyelid. So if you see, the action is the name elevation of upper eyelid. That is the action of levator palpebrae superioris. Yes, all of us knew that already, I know. Number 2, let's move on to the second muscle, everybody. The second muscle is MR. The full form of MR, again, everybody knows, medial rectus. Now comes the question, what is the action of medial rectus, everybody? So, medial means, everybody, towards the midline. Yes, lateral means away from the midline. So, rectus muscle, which is named medial rectus, must be moving my eye towards the midline. So, that means my eye must be moving inwards. Yes. So, medial rectus action is inward movement, and inward movement is known as orthopedics if you have read, anatomy if you have read, ophthalmology if you have read. Yes, very good. Adduction. Okay, adduction or adduction. Now, the third muscle in this list, everybody, LR. The full form of LR is lateral rectus. Lateral, as I just explained, means away from the midline. That means my eye will be moving outwards. Outward movement known as, yes, again everybody, abduction. Very good. Abduction. Okay. Now, these are two words which you should not forget, but alas, a lot of us tend to forget due to various reasons. I will not get into those. So how to remember them, everybody? I can tell you a simple way, everybody. Let me first explain it in simple terms. SO4LR6. Yes. So we know that lateral rectus is supplied by 6th cranial nerve. So if I ask you what is the name of the 6th cranial nerve, you know abducens nerve. I hope you understand how to remember abducens nerve, muscle lateral rectus, action abduction. Okay, everybody. So abducens, abduction. Or everybody, if we see the difference, there is only one letter which is different between the spelling of adduction and abduction. That is B, everybody. So B से हम कह सकते हैं बाहर. The Hindi word bahar means out, everybody. Okay, so I hope you will be able to remember abduction. Two ways, everybody: abduction or abducens nerve, and abduction B for bahar ki taraf. Very simple word. We should not forget this, everybody. Okay. Now, there are 3 muscles done, 4 muscles pending. For the 4 muscles that are pending, the superiors and the inferiors, we make a table because they have multiple actions. So multiple actions, we say primary action, we say secondary action, we say tertiary action. The muscles are number 4 SR. The full form I hope you know. If you don't, then I'm writing for you. Superior rectus. Number 5 IR. Inferior rectus. Number 6 SO. Superior oblique. Yes. So apart from the recti, the group of muscles is called as obliques. 7th IO. Inferior oblique. This should be very basic knowledge to all of you because all of us do cover it during our anatomy first year, everybody, extraocular muscles. Yes. So these are the 4 names: superior rectus, inferior rectus, superior oblique and inferior oblique. All these muscles have number of actions: primary, secondary and tertiary. Let's begin with the primary action of superior rectus. As the name says, superior. When I hear the word superior, I think up or down, everybody. I think up. So what is the action of superior rectus? To look up, everybody. And to look up is known as the English word elevation. Okay, simple. If the action of superior rectus is elevation, by name, by virtuoso, inferior rectus, inferior means down. To look down, we say depression. Okay, simple English, guys. No confusion here, I hope. Now, primary action easy for both superior rectus and inferior rectus. What about the secondary action? Secondary action for superior rectus is called as intorsion. Intorsion. Remembered by the mnemonic SIN. Sin. Very old mnemonic, everybody. Has been taught since ages, everybody. S for superior muscle, IN for action, intorsion. If the action of superior rectus is intorsion, by virtuoso inferior rectus becomes opposite. Opposite is extorsion. So intorsion, extorsion. I hope I'm being pretty clear here. Now, what is the meaning of these words intorsion and extorsion, everybody? Let us focus, everybody. Let us focus on the four words that we actually know. Let's assume these are my both eyes, everybody. Yes, my left eye and my right eye. I do this action, everybody. That means where are they going, everybody? Elevating, elevation. Bring back to normal. I bring them down. They are depressing, depression. Okay, now look, everybody. Where is my right eye going? What is the action being performed? Tell me. What is the action being performed? Right eye moving outwards is abduction. Yes, very good. Where is my right eye moving now? Right eye moving inwards, adduction. Okay. So these are four movements which you can actually see in my eye also. If you want to see, I'll show you. Everybody, look at my eyes. I look up. Which action? Which action? Elevation. Very good. I look down. Which action? Depression. Now I'm looking to the left, everybody. Left. Tell me what is the action in my left eye. My left eye has moved outward. That means it is abduction. What is the action in my right eye? My right eye is moved inwards. That means it is adduction. Yes. So these four words, these four movements you can very easily see whether by my hands or by my eyes. Yes. But what is the word torsion, everybody? That is where your English again comes in. Torsion, torsion force, torsional force. Think about cars. Torsion, torque. Torsion or torque means rotation, rotatory force, everybody. Yes. So when I'm talking about intorsion or extorsion, I am talking about a movement, but that movement is along my z-axis. So the eyeballs are merely rotating. That is the point to understand. That is the point to hear, everybody. My eyeballs are moving, but they are actually just rotating, everybody. They are at their own place in x or y axis. They are not moving up, down, left, right. They are merely rotating. So if there is intorsion, I am saying my eyeballs are rotating inwards. If there is extorsion, I am saying my eyeballs are rotating outwards. Intorsion, extorsion. Intorsion, extorsion. Or if I show you both hands, intorsion, extortion. Okay, everybody? Am I making myself very clear? Inward rotation, outward rotation. Now, why am I stressing on this? Look at my eyes, everybody. Can you tell me which action am I performing? Can you tell me which action am I performing? No, you can't. Because you can't see up, down, left, right. We can see X and Y. We can't see a sphere rotating around its axis, everybody. Why can't we see? Because our eyes are homogeneous spheres, everybody. We can't see them rotating. So if I'm performing intorsion or extorsion, if my eye is having intorsion, extorsion, you won't be able to see that. That means, listen carefully, that even though intorsion and extorsion are actions, but they are clinically not visible. So if you come to me and say, sir, I have examined a patient and he has loss of intorsion, I know you are joking. Or I know you are not using your brain, because intorsion and extorsion are clinically not visible. Even though the actions keep on occurring every time, every second, every minute, everybody, but they are not clinically visible. Am I making myself very clear? Don't get confused between adduction and intorsion. Again, I will repeat. Adduction is inward movement. Inward movement, you can see. Intorsion is inward rotation. Eyeballs are at their place. They are just merely rotating around their own axis. Okay, everybody? Done? Okay. Now, let's deal with tertiary action for now. What are the primary actions of the obliques, everybody? It is very easy to remember. I simply say the secondary actions of the rectus become the primary actions of the obliques. So, what am I trying to say? I am trying to say that superior oblique primary action is intorsion. Inferior oblique primary action is extorsion. I hope pretty easy to remember, everybody. Yes? What about the secondary actions of the obliques? The secondary actions of the obliques are like the primary actions of the recti but opposite. Too fast? So let's understand. Superior oblique, by the name, it should have caused elevation being superior, but instead it causes the opposite, depression. Okay? So like the primary actions but the opposite of primary actions of the recti. Whereas inferior oblique causes elevation. Am I pretty clear here, everybody? Yes? Now, the mnemonic which we have used gets followed. If you see, superior rectus causes intorsion, superior oblique also causes intorsion. So, sin is followed. Am I clear? Now we are left with the tertiary actions. So, for tertiary actions, I remember a mnemonic. What are my blood groups? My blood group is A, B or O. Yes, these are the three letters we can use for blood groups. This becomes a mnemonic. A, B and O. O for which muscles are we talking about, everybody? Obliques. And A, B for abduction. So I say if the tertiary action of the obliques is abduction, I can remember that the tertiary action of my recti is adduction. Am I making myself very clear here, everybody? Yes. All these are simple questions. They are basic to understand squint, but they're themselves asked as MCQs. What are the actions of extraocular muscles? They can give you any action. They can ask you to match the muscle, or they can ask you a muscle and they can say, they can ask you which of the following pair of actions is correct for the given muscle. I hope I'm making myself very pretty clear. These are the actions of extraocular muscles. So the actions that all of us have just learned, they are the anatomical actions of the muscles. There is another set of actions, everybody, which is slightly different from these anatomical actions, and those are called as clinical actions, or the clinical testing of a muscle based on some movement. Now, what is this complication here, everybody? Let's understand in very simple words. If I cut all the nerve supplies of all the muscles, everybody, still my muscles will be able to perform ocular movement by external force due to the direction of their muscle tendon. What do I mean to say? Let's say all the muscles are cupped. I hold the superior rectus and I pull the superior rectus. So the eyeball will elevate. Why is that so? Because the muscle tendon of superior rectus starts from my apex of orbit and it comes and gets inserted superiorly. So when I pull the superior rectus muscle, the eyeball moves up. Opposite for inferior rectus. The starting origin is from the apex of the orbit and it gets inserted on the inferior surface of sclera. So when I pull the inferior rectus, my eyeball goes down. So anatomical actions, I can say in brief, are actions due to the direction of the muscle tendons, right? But what if we take into account all the neurological inputs? What am I trying to say? Just to give you an example, when I look towards the left side, my left eye, as we have already seen, performs abduction. My right eye performs adduction. Different eyes performing different movements together, controlled by different nerves. Left eye performing abduction, left lateral rectus, sixth nerve. Right eye performing adduction, medial rectus, third nerve. Everything is different. The muscles are different. The nerves are different. That means there has to be some coordination, everybody. So this basic fundamental, when the neurological input comes into effect, we say the muscles perform slightly different actions, and those are called as clinical actions. Okay. Using this table only on your screen, everybody, we will discuss the clinical actions. We will first learn them and then understand why are they different from the anatomical actions. Okay. Okay. So I'm writing here, everybody, rule for clinical actions. The rule for clinical action says that all the primary actions of muscles, these actions, everybody, primary actions predominate in abducted eye. Okay. That means each eye will preferably perform its primary action when the eyeball is abducted, whereas all the secondary actions, everybody, secondary actions of each muscle predominate in adducted eye. Okay. Through whatever explanation I will give you in the next 5 minutes, this is the gist of it that we will arrive at. That all the primary actions predominate in an abducted eye and all the secondary actions predominate in an adducted eye. Using this fundamental, if I ask you what is the clinical action of superior rectus, everybody, let's see the table. There are two actions of superior rectus, elevation and intorsion. Which should be the clinical action, elevation or intorsion? I have explained this. Intorsion is not clinically visible. That means the action should be elevation. Elevation is the primary action. So what I will say, everybody, that the clinical action of superior rectus is elevation in abduction. Can I say, everybody, that the primary action of superior rectus is elevation in abduction? Am I making myself very clear? Let's see, everybody. Inferior rectus. What should be the action, everybody? Depression. Again, primary action in abduction. No confusion. Now let's see superior oblique. Superior oblique again has two actions, in torsion and depression. In torsion, even though it is the primary action, cannot be clinical because it is not clinically visible. So we move on to depression, which is the secondary action, and that is why the answer changes. So the clinical action of superior oblique is depression in adduction. And similarly, inferior oblique is elevation in adduction. Am I making myself very clear? So let us first write. Yes, I will explain, don't worry. Let us first write and then we will understand why that happens. Clinical actions or clinical testing. Superior rectus. Superior rectus is, everybody, again I'll say, elevation in abduction. Inferior rectus is depression in abduction. Superior oblique is depression in adduction. Inferior oblique is elevation in adduction. Okay. Based on the table and the rule for clinical actions that I gave you, this is what we can learn. I hope there is no confusion. I hope you can learn this. Okay. Now let me ask you a question. Let me see whether you can answer this. Superior oblique. Let's say a patient comes to me with suspicion of superior oblique palsy. Okay. I have a suspicion that the patient is having superior oblique palsy. You are my intern. I ask you to check the movements of the eyeball to ascertain whether the patient is actually suffering from superior oblique palsy or not. Which action of the eye will you ask the patient to perform to be able to rule out superior oblique palsy? You understand the question? Everybody? Everybody? Yes? So let's see. Will you ask the patient to perform intorsion? We already know intorsion is not clinically visible. That means we will ask the patient to perform depression. Okay. Ask the patient to depress. Let's say I am that patient. I have been able to depress. But I can depress even if my superior oblique is palsied. Why? Because I have one more depressor. That depressor is inferior rectus. So what do I do? See, that is where the clinical testing comes into effect. So there are three ways I can depress. Number one, let's talk about the right eye. I depress in primary position. That means I'm not adducting or abducting. I'm still depressing straight. So both muscles are acting, superior oblique and inferior rectus. Secondly, I depress and abduct. Okay. So depression in abduction. Depress and look out. Everybody. That means which muscle is primarily acting? Abduction, depression, as you see on the screen, the answer has to be inferior rectus. Thirdly, I am depressing and adducting, everybody. Depression in adduction. That means which muscle am I primarily using now, everybody? Superior oblique. I hope you understand what I'm getting at here. Yes? So again the question. Patient with suspicion of superior oblique palsy comes. What action will you ask the patient to perform? Everybody. Yes, sir. Now depression in adduction. Depression. Depression. What is depression? I don't know. What is adduction? I don't know. So what will you ask the patient to do? See, these questions have to be answered in the patient's language. We are talking about an OPD thing here, everybody. We can't say depression. We can't say adduction. We can't keep throwing these fancy words at the patient. Okay. We ask the patient to look down, depression, and in. Down and in. Down and in. Oh, no. This need not be done. See, again, the patient does not understand. What do you mean by down? He will move his neck down. He will look inside his clothes. No, down and in. What do you mean by that? So again, think about it, everybody. When you are asking the patient to look down and in, what is the structure, everybody? Tip of nose. So everybody, I ask the patient to look at the tip of the nose. Can you see both my eyes? I've opened them wide for you. I am looking down and in. Can you see, everybody? Both my superior obliques are functional. So if somebody asks you the question, how to test the clinical action of superior oblique, ask the patient to look at tip of nose. Am I making myself very clear here, everybody? Yes? Done? Do we understand the clinical actions? No. Have we learned the clinical actions? Yes. Now let us try to understand taking the example of superior rectus here, everybody. Let's see this image. In this image, what we can see a diagrammatic representation of the orbit. This is the medial wall of the orbit, the nasal bone. This is the lateral wall of the orbit, everybody. This is my eye and these are the muscles. This muscle, everybody, is my superior rectus. Okay. What is the direction of my superior rectus muscle? Has been marked with this arrow. But what is the direction of my visual axis, everybody? This is the direction of my visual axis. The angle between the visual axis and the axis of superior rectus is equal to 23 degrees. The muscle becomes a pure elevator when the visual axis is equal to muscle axis. Okay, everybody? Visual axis is equal to muscle axis. Now, when my eye will abduct by 23 degrees, visual axis is the same as muscle axis. Can you understand? When my eye abducts, looks out by 23 degree, my visual axis will become the same as muscle axis. And that is when my superior rectus will become a pure elevator. So we see that elevation will predominate in abduction in case of superior rectus, which gives us our clinical rule that all the primary actions predominate in abduction. Okay, you can do this for all muscles and the answer will still be the same, that all primary actions predominate in abduction, whereas all the secondary actions predominate in adduction. Am I making myself very clear here, everybody? Yes. Thus, we can summarize that the clinical actions and anatomical actions are different from each other. Let's see, everybody. These are my anatomical actions. Okay, everybody. As you can see, everybody, for each muscle, let's say superior rectus here, the action is elevation, the action is adduction, and the action by this arrow, it is rotating inwards, is intorsion. Okay. But if we see the clinical actions here, everybody, so this is a figure of the clinical actions. The clinical actions are different, everybody. If we focus at superior rectus, see which action it is performing. Elevation in abduction. It is going up and out, everybody. Am I clear to everybody? Yes. I've told you, I've shown you the photograph, I explained you the reason. I hope you are able to learn this. It is a very important base concept for anatomy questions as well as for squint. Done? Now that we know the actions of extraocular muscles, everybody, what I am interested in is teaching something called as binocular single vision. Now, why are we discussing this word, binocular single vision? This though we may have come across during physiology actually. What is binocular single vision? Binocular single vision is a state of my vision and your vision right now. I have two eyes, but I can see one image. Two eyes looking at one single image, binocular single vision. Why is binocular single vision possible, everybody? Binocular single vision is possible because both my eyes are looking at the same object. Both my eyes are looking at the same object because both my eyes are looking in the same direction. So if I extrapolate it, it means in squint, everybody, because my eyes are deviated, they look in different directions, I will have loss of binocular single vision. So can I say binocular single vision is a normal state, but squint is an abnormality in which there is loss of binocular single vision? Am I making myself clear? So let's first understand the physiology of binocular single vision, where we read grades of binocular single vision. There are 3 grades, everybody. Grade 1 is called as SMP, simultaneous macular perception. Simultaneous macular perception. That means images are formed at the same time on both the macula. Okay. So let's say, see this image, everybody, image 1. This is grade 1. In one eye, image of lion is shown. In the other eye, image of cage is shown. But because there is simultaneous macular perception, the patient will perceive that there is a lion within the cave. Okay. Grade 2. Grade 2 is fusion. Fusion means whatever image is transmitted in right eye, whatever image is transmitted in left eye, both go in the brain and fuse with each other or superimpose each other. Okay, this is explained through this image, everybody. Grade 2. We have an image of a house with only one tree. On the left side, another image on the right side tree. But what the patient perceives is a house with both the trees, because at last both the images are superimposing, everybody. Fusion. Okay. And then grade 3. Grade 3 is called as stereopsis. Stereopsis is defined as binocular depth perception. Okay, everybody. So basically we are saying, because both our eyeballs are looking at the same object from different angles, everybody. So we are able to judge the depth of it, everybody, which can be shown through this crude diagram of matkas, everybody. We are looking through here, so our two visual axes are coinciding and giving us depth also. Or if you know general knowledge, everybody, you know this. Humans are at the top of the food chain because they have binocular single vision, because they are able to perceive depth. Animals usually have eyes on opposite sides, so their field of view is larger, but they don't have depth perception. Depth perception is very important function which we use in our living, everybody. Yes, I hope we understand grades of binocular single vision. Now, after we understand the grades of binocular single vision, we answer a very important question. How does binocular single vision occur? Okay. What makes binocular single vision possible? If we understand this, we understand the normal fundamental, and thus we will be able to understand squint also. Let's see, how does binocular single vision occur? For this, I will teach you 5 points. Point number 1. I ask you, what are antagonists? I hope you know. And I ask you point number 2, what are synergists? Again, through anatomy, I hope you know both these words. Let's first see the word synergists, everybody. What do you mean by a pair of muscles which are called as synergists? Synergists are a pair of muscles having, everybody, a pair of muscles having, yes, same action. Very good. A pair of muscles having same action will be called as synergists. Right? So if I write an example here, let's say I am writing right superior rectus. These are the kind of short forms we use, everybody. Instead of writing the whole name, RSR, right superior rectus of the right eye, and left superior rectus of the left eye. Are they performing the same action, everybody? Pair of muscles performing the same action. Right superior rectus looks up, left superior rectus looks up. So are they a pair of synergists? I hope you understand. Yes? No. This is the wrong example, everybody. Again, this is a mistake that we make. We presume this because we do not learn the complete definition of synergist, so as to say. A pair of muscles having same action in same eye. Okay, everybody. So it is very important to understand that action should be same, but the eye should also be the same. So what is the correct example? Right superior rectus. And first of all, make the eye same. Then make the action same. So what is the action of superior rectus? What is the action of superior rectus? Elevation. Which other muscle causes elevation, everybody? Obliques. Which other oblique? Yes, inferior oblique. So this is the correct example, everybody, of a synergist. Okay, I hope you understand. If you understand this, then antagonist becomes very easy. Antagonist means a pair of muscles having opposite action. But again, in the same eye. So, if we ask an example, right lateral rectus will perform right eye abduction, and right medial rectus will antagonize it by performing right eye adduction. The eye remains the same, the action becomes opposite. I hope we are pretty clear about this. Right, guys? Done? Moving on with the discussion, everybody. The third point to understand is something known as yoke muscles. Antagonist synergists all of us have heard, but yoke muscles is probably new. Yoke muscles are also termed as contralateral synergists. Contralateral synergists. Now, let's first write down what they are, then try to understand. Yoke muscles are a pair of muscles, one in each eye. If you understand the word contralateral, and I have written the word contralateral synergists, you understand yourself. I am talking about both the eyes. Contralateral, yes, one in each eye. A pair of muscles, one in each eye, which help both eyeballs to move together in the same direction, which is known as version or conjugate movement. Everybody? The first point, as I have again stressed, one in each eye. The second point, which help both the eyeballs to move together in the same direction. Okay? If you've written it, let's try to understand, everybody. I will again use the example where I look towards the left side. Now let's try to understand that example through the eyes of yoke muscles. I look towards the left side, everybody. Left eye is using which muscle? Left lateral rectus. Right eye is using which muscle? Right medial rectus. Eyes are different, muscles are different, actions are different, and nerves are different. Sixth nerve and third nerve. Everything is different, but what was the same? The same was direction of movement. Okay, everybody? So two muscles, everybody, one in each eye, one in the right eye, one in the left eye, right medial rectus, left lateral rectus, enabling both the eyeballs to look together in the same direction at the same time, everybody. This is a pair of yoke muscles. They are being called contralateral synergists, even though they don't have the same action, but they are enabling the eye to move in the same direction. So they are loosely termed as contralateral synergists. That is why we don't focus on the name, rather we focus on the name yoke muscles. Okay. Binocular movement is known as version. If you have understood, everybody, uniocular movement is known as duction, abduction, adduction. But when both the eyeballs move together, we call it version movement, everybody. Okay, done? Now, what are the examples of yoke muscles? The first example of yoke muscle, everybody, I've just shown you. What I showed you? Left lateral rectus, yes, and right medial rectus. Am I absolutely clear? If I ask you, what is the action of this pair of yoke muscle? What is the action of left lateral rectus and right medial rectus? What will you like to tell me? Yes, you will tell me, sir, both these muscles enable to look towards the left side. But let's try to answer it in a way that it becomes a one-word answer. So for this, we use chemistry, everybody. In chemistry, we used to use two words, levo and dextro. Levo, left side, dextro, right side, everybody. Yes. So left side means levo, and the movement together is called as version. So we say the muscles responsible for levo version of eyes are left lateral rectus and right medial rectus. Second pair, everybody. Now if I ask you, I need to look towards the right side. Think about it. I need to look towards the right side. Which muscle, everybody? Right lateral rectus, abduction, and left medial rectus. Okay. Very easy to understand. Right lateral rectus and left medial rectus. I hope you are getting through, everybody. Yes. Looking towards the right side. Instead of levo, it becomes dextro. And the movement remains version. So we call it dextroversion. Okay. These are the two simplest movements to understand as far as yoke muscles go. Now, let's make our life a little bit more complicated. Just a little bit more complicated. The third pair of yoke muscles, everybody. I ask you, what is the yoke muscle for right superior rectus? I'm asking you, everybody, what is the yoke muscle for right superior rectus? Think about it. We know yoke muscle should be helping both the eyeballs to move together in the same direction. What should be the answer? First of all, can I write left here? We know there is one muscle in each eye. Yes or no? Yes. So now you must be thinking, or you should be thinking rather, I can say, that superior rectus causes elevation. So the left eye should also be elevated. Very good. So that means I can have two options. Left superior rectus can be the yoke muscle because it causes elevation. But left inferior oblique can also be the answer. Inferior oblique also causes elevation. Yes or no, everybody? So now the question comes, out of the two possible options, what is the correct answer? For that, let's try to understand, everybody. This is the first time I'm explaining you this. I hope you will be able to understand this. Let's say this is a rough diagrammatic representation, not a very good diagrammatic representation of my two eyes. Right eye, left eye. We are looking at a patient, everybody. Okay. Now, what is the action of right superior rectus? Right superior rectus we know causes elevation in abduction. We are talking about the clinical movements. Yes. Elevation in abduction. That means I am going to look up and I am going to look out. So my vector will become in this direction. Okay. So for the left eye also, I want to look in this direction. So that means what do I want my left eye to do? Elevate and adduct. Yes or no? So that means left eye I want elevation in adduction. Am I making sense here? Elevation and adduction is an action of inferior oblique. Elevation, secondary action predominates in adduction. So I hope we understand the answer here. The answer will not be left superior rectus. I am rubbing it, I am writing it, everybody. The answer will be left inferior oblique. Am I making myself very clear here? Or the other way to do it was very simple, everybody. Flip the name. I call this technique flip the name. Flip the name. What do we mean by this, everybody? Right becomes left, superior becomes inferior, and recti becomes oblique. Job solved. Done. As simple as that, everybody. Right, left, superior, inferior, recti, oblique. Everybody just keep flipping these three words and you get the yoke muscle, everybody. Okay? Now, this was the easy part. Yes, this was the easy part. Now answer, everybody, the slightly more easier part, I can say. I don't know. What is the action of both these yoke muscles together? So everybody, let's see, where are both the eyeballs looking? Up or down? Up. Elevation. Towards which side, everybody? Right side or left side? See, this is the right eye, so this is the right side, everybody. So the eyeballs are looking right and up. Right means what word, everybody? Dextro. Up means what, everybody? Elevation. So that means the action together is known as dextro elevation. I hope we are clear. I hope we are. Take 30 seconds, pause, relook at it. If not, look at my hands, everybody. This is the other way I can do it. Right eye, left eye. Right eye, left eye. Think about right superior rectus. What is the action of right superior rectus? Superior rectus causes elevation in abduction. Superior rectus causes elevation in abduction. So right elevation, abduction. Okay. Now left has to follow the same movement. So it will elevate and now it has to move towards this side. So it will move in adduct. Okay, everybody. So where are my hands going? My hands are going up and towards the right side, everybody. Right superior rectus, left inferior oblique, going up and right side, dextro elevation. Okay. Let's see another example so that you reaffirm this idea in your head. Next example of yoke muscle, everybody. What is the yoke muscle for right inferior rectus? First of all, everybody, let's use the technique flip the name. I am writing here. Flip the name so that you remember. Flip the name. Right becomes left, inferior becomes superior, recti becomes oblique. We get the pair. Okay. Now let's see what will be the action, everybody. What will be the action of this pair of muscle? Let's perform. Let's keep my both hands out. Right inferior rectus, inferior rectus, inferior rectus causes depression. Inferior rectus depression, primary action. So depression in abduction. So what does my left superior oblique cause? Left superior oblique. Superior oblique causes depression in adduction. Okay. So what is the pair doing, everybody? Both the eyeballs are going down. We see that the inferior rectus caused depression in abduction. This is causing depression in adduction. So where are both my hands going? Down and towards the right side. So the answer becomes, yes, the answer becomes dextro depression. See, you need to move your hands, guys. If you think you will be able to remember them just by looking at them, no. This has to be practiced, everybody. Once or twice if you do it, then you get it in your subconscious mind. You can see yourself performing those actions. If you don't understand by hands, I will again draw the eyes and I will again try to explain to you in very simple language. Right inferior rectus. Inferior rectus causes depression in abduction. So this is where I end up looking. Left superior oblique causes depression in adduction. So this is where I end up looking. So my position becomes this. Right side and down. Dextro depression. Okay, everybody. Moving on to the next pair. I hope you are able to understand them. What is the yoke muscle for right superior oblique? The answer should become very easy by flip the name. Left inferior rectus. Okay, everybody. Again, we want to see what is the action of both the muscles together. Let's move our hands again. Right superior oblique. Right superior oblique will cause right eye depression in adduction. Left inferior rectus will cause left eye depression in abduction. Depression towards which side, everybody? Left side. Yes. So the answer becomes levo depression. Okay. Next pair, right inferior oblique and flip the name. Right becomes left, inferior superior oblique rectus. Okay, last pair, only one thing left, everybody. I hope you understand. Inferior oblique causes elevation in adduction. Superior rectus causes elevation in abduction. So again, where are my hands moving? Up and towards which side? Left side. So the answer becomes again, everybody, levo elevation. Okay. I hope we are clear about these four pairs of right superior and left inferior. Okay. Whether obliques or recti, everybody. We use the simple technique of flip the name for the yoke muscle pair, and then we use our heads and our hand, everybody, to understand what is the direction of action. Apart from these 6 main pairs, I can say there are 2 more pairs. See carefully what I am writing. Right superior rectus plus right inferior oblique and left superior rectus plus left inferior oblique. What am I trying to say? 2 muscles of the right eye synergists which will cause right eye elevation. 2 muscles of the left eye again synergists which will cause left eye elevation. So now we are saying both the eyeballs are looking up. When both the eyeballs are looking up, all the 4 elevators are acting together. So basically bilateral elevation. This is known as circumversion. I know, making our life difficult, but that is how medicine is, everybody. Last pair, I hope you understand by common sense. Right inferior rectus plus right superior oblique and left inferior rectus plus left superior oblique. Again, if you focus your mind, inferior rectus and superior oblique both are depressors. So I am causing right eye depression and left eye depression. So again, this is bilateral depression of the eyes. Both eyes looking down, straight down. This is known as Dior-Sum version. This is known as Dior-Sum version. Okay, everybody, no confusion about this. So these can be the 8 pairs of yoke muscles, everybody. So I hope you are able to answer them, and morely you have been able to understand them, everybody. Okay. Now, going back to our topic of how does binocular single vision occur. We have read 3 points till now. Antagonist, synergist, yoke muscles. The 4th point is a law. The name of the law is Hering's law. Okay, what is Hering's law? Hering's law of equal innervation to a pair of yoke muscles. Hering's law of equal innervation to a pair of yoke muscles. What does it mean? It is basically trying to say what we all know all along, everybody, that equal impulse in terms of time duration, in terms of the threshold received, everybody, should be equal, everybody, to a pair of yoke muscles. If two muscles have to act together, they should receive the same amount of impulse and the same time duration of impulse. As simple as that. Okay, everybody? Hering's law is applied in two important conditions. One is secondary deviation and the other is inhibitional palsy. But it is not followed in one condition which is known as DVD, dissociated vertical deviation. We will discuss all these words as we move along in Squint, everybody. For here, these are straight MCQs which can be asked, so you should know. Point number 5. Another law, everybody. The name is Sherrington's law. Sherrington's law of reciprocal inhibition. Sherrington's law of reciprocal inhibition. What do we mean by this? Two simple English words, everybody. Reciprocal. Reciprocal means opposite. Opposite muscle means antagonist. So if I apply this much of brain, I know this law is talking about the antagonist muscle. And inhibition of a muscle means, everybody, it should not be able to work. It should not be able to contract. That means relaxation. So Sherrington's basically said that for two yoke muscles to contract, each of the antagonist muscles of the yoke muscle should relax. So the antagonist muscle should relax, everybody. Yes? If we understand Herring's and Sherrington's together, everybody, I can say, let's say I want to look towards the right side. If I want to look towards the right side, I have two yoke muscles which should contract. Right lateral rectus, left medial rectus. These should contract. Herring's law, equal innervation. But the two muscles which are the antagonists. What is the antagonist here, everybody? Right medial rectus. And here left lateral rectus. They should relax according to Sherrington's law. So which tells us, if you try to understand the gist of it, that for each binocular single vision, there are at least, not two, there are at least four muscles which act together. Two muscles will contract. The other two muscles will relax. Only then binocular single vision is possible. The two muscles which needed to contract, if they have a palsy, I won't be able to perform binocular single vision. The two muscles which needed to relax, everybody, the antagonist muscles, if they are not able to relax, if they have some spasm, everybody, again, I won't be able to perform binocular single vision. Okay, everybody? So through these 5 points, I hope we understand how binocular single vision occurs, everybody. If we understand the normalcy of how binocular single vision occurs, we understand that if there is loss of binocular vision, any of the four muscles gets affected, my eyeballs will not be able to move together in the same direction and I will end up with a deviation that will be known as squint or strabismus. Yes? So till now I have not taught you anything about squint, guys. I have just told you what is the normal, everybody. Now using this normal, let's start building upon our knowledge of squint. So now let's start with the classification of strabismus, everybody. Squint or strabismus can be broadly classified into two groups. The first group we call apparent deviation, and the second, let us say, true deviation. Now, deviation means squint, all of us know, but there are two English words here now. One is apparent, the other is true. What is the meaning of the word apparent? Apparent. apparent basically means it looks like. ऐसा लग रहा है. It looks as if there is deviation of the eyes, but we are not sure. Or we are trying to say, when we are saying apparent deviation, that it is just looking like squint, it is actually not squint. So we say this group is called as pseudo strabismus, where it just looks like squint, it is actually not a case of squint. Okay. Then we move on to the second group, that is true deviation, everybody. True deviation, by the name itself, it is very clear. It is a deviation and it is an actual deviation. Yes. Okay. So when we are talking about squint per se as a word, we are talking about true deviation. Yes. So true deviation can further be divided or classified into two groups. The first group we say has latent squint. And the second group has manifest squint. Now, first of all, let us write down the proper names for this. Latent squint, everybody, is known as heterophoria. The word being phoria. Whereas manifest squint is known as heterotropia. Again, the main word being tropia. So we can say true deviation is of two types. One is called phoria and the other is called as tropia. Phoria means latent squint. Tropia means manifest squint. This is what we need to learn first of all. After we've been able to learn this, everybody, again, it becomes a question of English, everybody. There are two words, latent and manifest. Okay. So what is the meaning of the word manifest, or what is the meaning of the word latent? Let's take the example of tuberculosis, everybody, to understand them better. I can say I have two patients. One is a patient of latent TB and one is a patient of manifested TB. What is the difference when I say both these words? Manifested TB means I know that the patient has tuberculosis and the signs and symptoms are visible. Let's say if it is pulmonary tuberculosis we are talking about, the patient has signs on X-ray, everybody, and the patient is coughing, there is sputum production, maybe there is hemoptysis, all those things, everybody. Yes? But then there is another case which I have labeled as latent tuberculosis. That means on testing, Mantoux test or whatever, everybody, quantiferon gold test, I have got TB positive. But the patient does not have any signs or symptoms at all. So, I am trying to say that a disease is present, but if it is not visible, visible means signs and symptoms not present, that is a case of latent disease. But if they are visible, they are a case of manifest disease. Okay. Let's apply the same fundamental to squint. Manifest squint. Squint matlab deviation is present and it is visible to me. Okay. In this image, what do we see? We see that the left eye of the patient is deviated. If the left eye of patient is deviated, I know it is visible. I know it has manifested. That means I am calling it a case of tropia. Okay, everybody? No confusion about this. What is latent squint? Okay. So, latent squint is squint which is present but which is not visible. Yes or no? This becomes a complex issue in itself. I am saying squint means deviation. So, I can say that a patient has deviation only when I see it. But then I am saying it is latent, that means it is hidden. I can't see squint, but still I am saying you have squint. So that means I can say that about myself also. I don't have squint. Squint is not visible in me, but I have squint. I can say that in all of you, everybody, look at your own eyes. You have squint, but it is just not visible. Based on these definitions, so the whole world will end up having latent squint. So latent squint should be something like this, but something more specific. Let us understand latent squint through a series of examples. In that example, all you need to remember is what is near reflex. If you do not remember, everybody, let me go back, refresh your memories. Near reflex, everybody, near reflex. We have read in first part of our video lecture series, everybody. Near reflex comprises of three parts. Number 1, accommodation. Number 2, convergence. And number 3, meiosis or meiosis. We have read this in part 1 of our lecture series, Anatomy of the Eye, everybody. If you don't remember, just a quick revision. Okay, accommodation, convergence, meiosis. Okay, now, let's hear the story. Let's say an 8-year-old boy comes to me in my clinic along with his or her mother. Boy, so his mother. The mother tells me, sir, I feel that sometimes the eyes of my child are deviated. Focus on the word sometimes. She's saying, sir, they are always not deviated, but sometimes they are deviated. Right now, I have brought him to you, but the eyes are not deviated. But sometimes they become, sir. I'm not imagining them, sir. I'm telling you the truth, sir. So I understand that the lady is talking about latent squint. Okay, but you don't. So I ask you to take the history of presenting illness. I ask you to ask the child. The child is a little dramatic. The child says, मैं जो कहूँगा सच के सिवा कुछ नहीं कहूँगा. The child says, sir, I am a very studious child. I come first in my class. I study a lot, sir. I love to study, sir. When I study continuously for 2 hours, sir, something happens, sir. Right now, the eyeballs which are straight, everybody, they become deviated. That is what the child is telling me. That when I sit to study, my eyeballs are looking in the same direction, but after 2 hours of continuous study, my eyeballs become deviated. Okay, right eye becomes deviated. He says, sir, when my eyeballs have become deviated, I can't see properly, so I can't study, so I go out to play. Sir, I love to play football, sir. When I go out to play football, sir, now I had studied for 2 hours, so I'll play football for 2 hours, sir, right? So when I come back after playing football, that is when the magic occurs. When I had studied, my eyeballs had become deviated. But when I come back after playing, my eyeballs again become straight. So I go to my mother and say, whenever I study, my eyeballs become bad, they become deviated. But whenever I play, my eyeballs become better, they become straight again. So should I study or should I play? My mother gets angry. But sir, I said the truth and only the truth and nothing but the truth, sir. Okay? So what was the child trying to explain to me? The child was trying to explain to me that when he uses his near vision for a long time, he is using his near reflex for a long time. Accommodation, convergence, and meiosis. Convergence. What do you mean by convergence? Convergence means eyeballs moving in or converging, everybody. So he's using muscles when he's using near work. His muscles get tired. The problem has to be in extraocular muscles, I have told you. When the muscles get tired, they are not able to maintain fusion. They deviate. Present with squint. When the child goes out to play football, everybody, he's not using his near vision, he's using his far vision. The muscles get time to relax. When they relax, they are able to function again. And again, the eyeballs become normal. They start looking in the same direction. So the child has told me, yes, sir, I have squint. But my squint is hidden. And it becomes manifest only under conditions of ocular stress. And what is ocular stress, everybody? Excessive near work. Okay, so let's write this if you've been able to understand. What is latent squint? Latent squint is hidden deviation which becomes manifest under ocular stress. And ocular stress is excessive near work. Okay, everybody, I hope we are able to understand this. There should be no confusion. I remember my childhood, my father used to tell me, don't study a lot without proper lighting. Because if I'm studying a lot without proper lighting, everybody, I am inviting the phoria to occur in me, everybody. Okay, now, once we know what is latent squint, once we know what is manifest squint, if we summarize it, we can say squint which is always visible, manifest squint. Squint which is visible only under conditions of stress, so sometimes visible, everybody, that is latent squint. Okay. Again, I ask you, if I mention only the word squint, which group I must be talking about, latent or manifest, everybody? Obviously manifest. So let's classify manifest squint further. Manifest squint can further be classified into two groups. One is called as committent squint and the other is called as incommittent squint. What is committent and what is incommittent? Committent squint is when deviation remains constant in all directions of gaze. Incommittent means when deviation varies in different directions of gaze. Okay, everybody? When deviation remains constant or when deviation varies. Now, what do I mean to say by this? Let's understand this, everybody. Let's say the child comes to me. What had the child told us? That when the eye deviates, it becomes like this. So the child is telling us my left eye remains straight, my right eye deviates outside. Okay? Whenever the patient comes to us for squint, we measure the degree of deviation. What do we mean by the degree of deviation? If the eyeball would have been straight, it would have been like this. Now it has deviated. So can you understand that there is an angle formed, everybody? Yes, angle of deviation. So let's say this angle of deviation is roughly 45 degree. When the patient presents to me, the angle of deviation is 45 degree. Now I check the deviation in all directions of gaze. That means I ask the patient to look up. Deviation remains 45. I ask the patient to look down. Remains 45. I ask the patient to look toward the right side. 45. To look towards the left side. 45. What am I trying to say? Wherever the patient may look, in whichever direction everybody, the deviation remains constant. 45 degrees. Okay? But if it would have been a case of incomitant squint, what would have occurred? The patient came with 45. I asked the patient to look up. It becomes 0, normal. I ask the patient to look down, it becomes 0, normal. I ask the patient to look towards the right side, it again becomes 45. But when I ask the patient to look towards the left side, it becomes more than 45 or 90 degree, let's say. So what am I trying to give you an example of? Incomitant squint. That the deviation varies whenever the eyes move up, down, left or right. Okay, everybody? To write it as a sign, we say primary deviation is equal to secondary deviation for comitant squint, and primary deviation is less than secondary deviation for incomitant squint. First of all, I hope you understand that when I say that the squint is comitant, it is constant. Constancy is denoted by the equal to sign. When I say incomitant, I mean variation. More than or greater than denote variation. Okay, this much is clear. Now, we have introduced two new words, primary deviation and secondary deviation. So now the question comes, what is primary deviation, sir? What is secondary deviation, sir? Very easy, everybody. Everybody, look at the first image. This is when the patient presents. Patient presents with 45 degree exo, okay, in the right eye. I hope you understand. Right eye 45 degree exo. This is what the patient presents to me with. This is primary deviation. Now, I ask the patient, everybody, I ask the patient to look at the object. Let's say this is the object from the right eye. You are the object. This is the case. Right eye 45 degree exo. I ask you to look at the object, everybody, through the right eye. So what will the right eye do in such a case, everybody? What will the right eye do? The right eye will have to move in. The right eye will have to perform adduction. Yes? To perform adduction, right eye will need innervation in a muscle. Which muscle, everybody? Right eye will need right medial rectus. Yes? But we know along with right medial rectus, one more muscle will receive innervation because of Hering's law. Because of which law, everybody? Hering's law. Hering's law of equal innervation to a pair of yoke muscles. Right medial rectus is getting innervation, so left lateral rectus will also get innervation. What will be the ultimate result, everybody? That the right medial rectus will enable the right eye to move in and look at the object, but the left lateral rectus will make the left eye look out, everybody. Yes? So now what will occur, everybody? Patient presented to me with this, everybody. Yes? This was the state of presentation. Left eye looking at the object, right eye 45 degree exo. Now due to the movement, right medial rectus makes the right eye move in, but the left eye moves out due to left lateral rectus. So do I have another deviation visible? Yes? This is secondary deviation. I hope you understand. Why does secondary deviation occur? Due to Hering's law. We had already noted it down, yes or no? Why does secondary deviation occur? Due to Hering's law. So if I put it in words, everybody, what is primary deviation? Primary deviation is when the patient presents to me, normal eye looking at the object. Secondary deviation is when the deviated eye is looking at the object, the normal eye gets deviated, and that is called as secondary deviation. Okay, everybody? Primary deviation, normal eye looking at object. Secondary deviation, deviated eye looking at object. I hope we are clear about the two words, and we are clear about the fact that secondary deviation occurs due to Hering's law. Okay. Now, if we understand this much, let's write down certain other differences between comitant and incomitant squint, everybody. Okay. I am writing in the center one word, diplopia. Diplopia means double vision. Double vision is present in a case of incomitant squint, but it is absent in a case of comitant squint. Similarly, head posture is present in a case of incomitant squint, absent in a case of comitant squint. Sensory anomalies are present in a case of comitant squint, but absent in a case of incomitant squint. All these words I will be using as we move further along. This is the differences between comitant and incomitant squint in a tabulated form, so that if a simple question is asked, all of the following are true about, you can answer that question. I will explain everything as we move along, as and when, wherever it is required. Okay, guys? Now, lastly, ocular movements are restricted if it is a case of incomitant squint, but they are full, or I can say normal, if it is a case of comitant squint. These are the differences between comitant and incomitant squint. The basic difference being whether the deviation remains constant or whether the deviation varies. Okay. Now, incomitant squint can be of two types. Incomitant squint can be of two types. The first word we use is known as paralytic squint, and the second word we use here is restrictive squint. Now the names themselves should make this very clear, everybody. Paralytic squint means due to paralysis of cranial nerves. Restrictive squint means restriction. Understand? We are talking about an external force. We are saying the muscle is normal, we are saying the nerve is normal. But there is an external factor which is not letting the eye move. Okay, everybody? Now, both these can be differentiated on a test, which is called as forced duction test. What do we do in forced duction test? We test for restriction. We test for restriction by applying external force. Okay, let's try to understand. Let's say the eyeball is not able to move up on its own. The eyeball is not able to move up on its own. What I do, I take a forceps, I hold the eye at the limbus, and with external force I try to push it up. If it is able to get pushed up, everybody, that means there is no external restriction. That means the problem was internal. That means the problem was paralytic. There was paralysis of superior rectus. That is why the eyeball was not able to move up. If I move it with external force, it is able to. But let's say it was not able to move up, everybody. If it would not have been able to move up, that means the problem would not have been in the muscle. The problem would have been external. Let's say due to fracture, there would have been a bony fragment here, everybody, which is not allowing the eye to move up, everybody. In that case, we would have said restriction is present. I hope you understand what I'm trying to show you here. So this is an example of forced duction test, okay, in which restriction is absent as eye moves with external force. Am I making myself very clear here, everybody? Yes? If I am, let's go back and let's write, everybody. Force duction test, tests for restriction by applying external force. If eye does not move, then I am saying restriction is present. If restriction is present, then my diagnosis is restrictive squint. Okay. But if the eye moves, as we saw in the image, that means restriction is absent. So if restriction is absent, that means it cannot be a case of restrictive squint. It has to be a case of paralytic squint. Yes, guys, I hope we understand this. There is no confusion in this. Now, if I ask you, everybody, force duction test is used to diagnose. Everybody listen to my question. Based on the knowledge that we have just received, force duction test, short form FDT, is used to diagnose. What is the answer, everybody? A, paralytic squint, B, restrictive squint, C, both of the above. It is used to diagnose. It is used to diagnose both of the above. If you are saying both of the above, then I have stopped using your mind, everybody. A test is said to be positive, everybody, then only it is diagnostic. So we are saying force duction test is positive, then only we are diagnosing restrictive squint. If it is negative, then we are saying because it cannot be restrictive squint, it has to be paralytic squint. So please remember, a test is diagnostic only when it is positive. So force duction test is diagnostic with squint, everybody, restrictive squint. I hope we are absolutely clear about this here, everybody. Yes, that's all about our classification of squint, everybody. Start from the top, everybody. Pseudo strabismus or true. If it is true, it can be latent phoria, only visible sometimes, or manifest tropia, always visible. If it is manifest tropia, it can be of two types: comitant, C for C, constant, incomitant, variation. There are differences. Then if it is incomitant, it can be due to two reasons, either paralysis or restriction, differentiated by forced duction test. That is your simple and short classification of squint or strabismus. Using this, we will study all the clinical features of all the groups of strabismus, everybody. So now that we know the classification of squint, guys, we know the basic groups of squint. But what is also important is to be able to tell the direction of deviation, the nomenclature. What do we mean by that? See, the squint basically means deviation which can occur in any direction, right? It can be upward deviation, it can be downward, it can be inward or outward. In all the cases, we have to give it a name. So basically, the topic is directions of deviation, the nomenclature in that. Now, let's study the nomenclature based on these images that we are showing. Let's look at image 1. What do we see in the first image, everybody? We see in the first image that the left eye is looking straight, everybody. Can I say looking straight? But the right eye, everybody, is not looking straight. It has deviated or moved inwards, everybody. As you can see, the arrow is marked. The right eye has deviated inwards or moves in. So inward deviation gets the name what, everybody? ESO. So ESO is equal to inward deviation. Are we clear about this? Now, let's move on to image 2. Very easy. Again, you will be able to see now. Again, look at the left eye. The left eye is straight. The right eye, in this case, instead of moving inwards, it has actually moved or deviated outwards. So outward deviation is called as EXO. So EXO is equal to out. ESO is equal to in, EXO is equal to out. These are the two important words that you need to remember, ESO and EXO. Now, moving on everybody, let's move on to image 3. Image 3 should be very easy for all of you to understand everybody. Again, the left eye is normal, but the right eye has deviated everybody upwards. Yes, we can see moves up, upward deviation, and upward deviation is known as hyper. Yes, very easy to remember. If calcium levels increase in our body, we call it hypercalcemia. So everything which moves up, everybody called hyper. So if I see image 4, everybody, in image 4, again I see left eye normal, right eye has moved down. So down, if up is hyper, down should be what everybody? Hypo. Are we clear? I hope here everybody. Yes. So 4 basic directions: up, hyper, down, hypo, in, ESO, out, EXO. Now, let's look at number 5 and number 6. Please remember that I have told you that intorsion and extorsion are clinically invisible actions. But if still theoretically we want to nomenclate that, we can nomenclate that. So let's look at these images carefully now. Left eye is not deviated anywhere. Yes. Also, if I have marked the vertical axis, you can see I have marked it with the red color now, or it is being shown with the yellow color already, everybody. We see that it is straight, but in the right eye, everybody, we see that the vertical axis has turned inwards. Okay. So let's assume that there is a marking given in the eye at 90 degree and at 270 degree. Okay. So let's say these 2 points were marked. Okay. So you wanted them to be straight vertically, but now because of intorsion occurring, they have moved obliquely. So you know based on these points that my eye has deviated by rotation. Okay. So this is intorsion deviation. Intorsion deviation gets the name encyclodeviation. Am I clear to everybody? Okay. So the eye rotating inwards, normal movement is called intorsion. Deviation is called encyclodeviation. Are we clear about this? Number 6, everybody. In number 6, what do we see? Again, the left eye has not deviated and the axis is straight. But if we look at the right eye, everybody, what do we see? That the axis has rotated outwards. The axis has rotated outwards. So outward movement is called as extorsion. Outward deviation will be called as excyclodeviation. Are we clear about this, everybody? Am I clear about the images here, everybody? So if we want to revise, let's quickly write, everybody. Simple. Number 1, if I say inward deviation, just to revise it with you, inward deviation will be ESO. Number 2, outward deviation will be EXO. Now, these are the names which I've usually seen students getting confused in. If not confused, they don't remember it somehow. So, how I remember it is, I write ESO. In front of ESO, I write an N. It becomes ESON. What is ESON? Nothing. But if I read it backwards, everybody, it becomes NOSE, nose. That means it becomes deviation towards the nose. And our nose is inside. We have not evaluated so much that our nose gets outside, everybody. Okay. So that's how I remember it. As soon as I hear the word ESO, I think about the nose, and nose or ESO means inward deviation. Are we clear? Now, number 3, everybody. If I talk about upward deviation by simple basic nomenclatures that we know means hyperdeviation. And lastly, everybody, downward deviation will be hypodeviation. Okay. So these are the 4 names you usually use in your MCQs or in your questions. I have shown you the images. I have told you the trick. I hope you will be able to remember that. And if you remember this much, you have become partial strabismologists, guys. What do I mean to say? So, in India, a lot of our relatives, as soon as we enter MBBS, they think that we have become doctors and they start asking us all kinds of diseases and questions. So, let's say one of your relative, a child comes to you and the relative is asking you, can you diagnose? So, yes, you can diagnose now. At least you can diagnose what is the direction and you can say tropia or phoria. Yes, they will think that you have become doctors. You haven't, you just know the nomenclature, but it will help you in good stead, everybody, right? So if you understand these are the basics of squint, everybody, this much is basically important to be able to understand everything else that comes after this. Okay, done? Now, after we know these basics, everybody, let me ask you a question. I have squint. Okay, I have deviation. That is visible in the eye. Okay. But what are the problems faced by me as a patient if I have squint? So, what are the consequences of squint? Right? I hope you understand. So, what are the visual problems that the patient will face if he or she is suffering from squint? So, there are two basic problems that we can group the consequences of squint into. The first is the word that you would have heard a lot of times, diplopia. Right? Diplopia in simple English means double vision. Right? So instead of one image, you see two images. The second consequence of squint, we can say, is confusion. Our confused brains are studying something called as confusion. What an irony, guys, right? No worries. Let us end all your confusion and about squint here. So let's start with the first consequence of squint, that is diplopia. Now, diplopia occurs in small angle squint. It occurs in small angle squint. Now, what does diplopia mean? Diplopia means two images of one object. Okay. What does confusion mean? Let's first write, then let's understand. Confusion occurs in large angle squint and it means two images of two objects. So if you understand, there are basically two differences here. Confusion will occur in large angle squint, diplopia will occur in small angle squint. In diplopia, you have double vision, but of the single object. In confusion, you also have double vision, but it is different because you see entirely two different objects. Okay. So let's understand diplopia first, guys. Diplopia, as we have written, occurs in cases of small angle squint. Small angle squint means deviation less than 5 degrees. Okay. So what is the visual system in this case? The left eye looks straight at the object. The right eye, everybody, even though it is deviated only marginally. Can you see my finger, everybody, which is representing the right eye move out? Yes. So let's say I have 3 degrees of exotropia. Even though I have exotropia, it is so small that the deviated eye, the right eye, will still be able to look at the same object. Am I clear? So even though deviation is there, both the eyeballs look at the same object. But what occurs about the visual axis? The left eye, which was straight, the light came from the object and formed an image on the left fovea. But the right eye, because it was deviated slightly, the image did not form at fovea. The image formed slightly nasal to fovea. Okay, everybody? Remember neuro-ophthalmology. Visual field and retina are opposite to each other. So now the image is forming slightly nasal to fovea. Now one image from the fovea, left eye, will go into the brain. The other image from the extrafoveal point will go into the brain. The brain will try to fuse both the images. Will it be able to completely fuse both the images? No. It will only be able to partially fuse both the images because the images are coming from non-corresponding points of retina. Do you understand what I'm trying to say? Each point in retina of left eye corresponds with a point of retina in the right eye. Fovea corresponds with fovea. But because now one image is at the fovea, one image is extrafoveal, they are non-corresponding points. So thus the images are not able to fuse with each other. And you end up seeing two images, but of the same object. Am I making myself very clear? Okay. So what we are writing here is that two images of one object form due to images in both retina being formed on non-corresponding points. I hope you understand this. Right, guys? Now let us compare this to confusion. Now we have written confusion occurs in large angle squint. So let's say large angle squint, this is the degree of deviation, 45 degree. Left eye straight looking at the object. right eye deviated looking at entirely different direction, so looking in an entirely different object. What is occurring? In left eye fovea, object 1 image is formed. In right eye fovea, image of object 2 is formed. 1 and 2 go into the brain and try to fuse with each other. Can two dissimilar images be fused by the brain? No. My brain is used to seeing just one single image, everybody. So as soon as I show him two images, everybody, I try to fuse two images, my brain gets confused. What is the confusion? My brain says, should I see object 1 or should I see object 2? Am I clear? So that is the consequence, everybody. So the consequence is called as confusion, because the brain is confused what to see, whether to see one object or object 2. You can't see both the objects at the same time. Okay. So two images of two objects, due to both eyes looking at different objects in absolutely different directions. Okay. So do you understand the difference between the two consequences, diplopia and confusion? It is basically based on the degree of squint. Now, our body is unique in the fact that it has a lot of adaptations to overcome the problems that are thrown to it. So because we have consequences, we have adaptations. So now, what are the adaptations to squint? So let us first see the adaptations to diplopia. So the first adaptation to diplopia is a motor adaptation, and this motor adaptation is known as fusion. Okay. So what is fusion? Let's try to understand. Because the degree of squint is very small, everybody, 2 to 3 degree, my brain says to my extraocular muscles, please act extra. Please have some extra strength to overcome this small deviation. In the example that we are seeing, the right eye is exo. That means the right eye has deviated outwards. So the brain is giving extra strength or extra impulse to my right eye medial rectus. So my right eye medial rectus is acting a little more and is trying to straighten my right eye to be able to fuse both the images. Are we clear? Very simple. Because it is small angle squint, so the extra strength of extraocular muscle will be able to overcome that squint, leading to fusion of both the images. Okay. Fusion due to extra power of extraocular muscles. Okay. Now, let's say my muscle says that I am functioning to my full capacity. I can't function anymore. So I do not have any extra power left for fusion. Then we have a sensory adaptation. The sensory adaptation is known as anomalous retinal correspondence. In short, ARC. Anomalous retinal correspondence. What do we mean by anomalous retinal correspondence? Everybody. The right eye again was deviated only slightly. So the images were being formed at non-corresponding points. Left eye fovea, right eye slightly nasal to fovea, or I can say extrafoveal. Okay. So my brain and retina talk to each other and they decide that from today onwards, the corresponding points will be changed. From today onwards, the left fovea will correspond with a right extrafoveal point. Okay. So now the brain is no more in trouble. It is saying that the retina has changed corresponding points. I will be able to fuse both the images and I will be able to see only one image. So what is occurring? Retinal correspondence is occurring, but it is not a normal retinal correspondence. It is an anomaly. Anomaly means anomalous. So a retinal correspondence which is not natural, but still it is occurring, unable to overcome diplopia. I hope we are absolutely clear about this, everybody. Yes? Now, let's move on to the adaptations of confusion. So number 1, everybody, motor adaptation. Motor adaptation is head posture. Head posture. In order to overcome seeing two different images, everybody, my head will turn left, right, up, or down to be able to adopt a position in which the deficiency of movement does not take into account. Okay. If you want to understand it, we will understand it further in paralytic squint. Number 2, sensory adaptation. Sensory adaptation is known as suppression. Now, what is suppression? This is important, everybody. Let's try to understand this. We said confusion was that my brain was seeing two dissimilar images. It could not decide whether to see object 1 or object 2. So what does my brain decide? My brain says, I am used to seeing only one image. I can see only one object, one image. I can't see two dissimilar images. So my brain says that from today onwards, I will suppress the image which is coming from the deviated eye. Okay, I will stop receiving the signal that is coming from the deviated eye. My problem is solved. I will be only able to see one image, object 1 from the normal eye. Okay, so suppression of the sensory impulse from the deviated eye. But even though the brain's problem is solved, the patient lands up in a problem. What is the problem the patient lands up in? The patient is losing vision from one eye. Yes, without any cause. There is no disease per se. I can't see any organic disease. Yes. So what do we call it? Suppression leads to amblyopia. Amblyopia, everybody, is loss of vision without organic cause. Okay, so even though suppression is an adaptation, it is not a positive adaptation, it is a negative adaptation for the patient, because the patient is going to lose vision from one eye and will land up in that dangerous word which we call as amblyopia. So as we will read forward, everybody, even though suppression is an adaptation, but do we want suppression to occur, everybody? Never. So as we will see in the treatment of squints moving forward, how to treat squint or how to prevent suppression in a case of large angle deviation. Okay, I hope we are here clear about the basic concepts, that there are two consequences. Either it can be diplopia, two images of the same object in small angle squint, everybody. Small angle squint, two images but of the same object, or we can have confusion in large angle squint, two different images of two different objects, everybody. And then there are adaptations. The first adaptation to diplopia is fusion. The second adaptation is ARC. In confusion, it is head posture, and the dangerous word, as I have explained to you, suppression leading to amblyopia. I hope we are pretty clear about this.